Good evening, everyone. This is Debbie Seidel-Bittke, and I am here with my friend and colleague, Dr. Roy Shelburne. And Dr. Roy, are you there on the line with us?
I am here.
Well, thank you for joining us tonight. You have been, I don't know, I'm giving you all the credit tonight, Roy, because we have so many people on this webinar. And it's been a constant stream ever since we made the registration live over 2 weeks ago. So thank you so much for taking time out. I know you're leaving on a plane probably first thing in the morning to the Chicago midwinter. So thank you for being here, Roy.
You're welcome. It's happy to be here. Thanks for having me.
Well, for those of you who don't know who my colleague is, Dr. Roy Shelburne, he's somebody who's going to walk his talk. I think Roy will tell us a little bit about why you're so passionate about what you do. I'll let you speak to that and tell them as much of the story as you wish to share tonight. But he is somebody that I go to, and I don't know if you're aware of this, Roy, but we have a web portal for our clients with video modules. And I talk about you in one of our video modules in particular because I consider you to be the expert on billing and coding and making sure that we cross our T's and dot our I's correctly so that we don't go to prison. If we're audited and we don't have the correct documentation, you know what that means for us, Roy, right?
Uh, all too well, I'm afraid.
Yeah, so I am the founder of the Dental Hygiene Empowerment Training, and we do coaching and consulting with offices throughout the world. I'm getting ready to go to Australia in about 45 days to work with a client there. So I invited Roy to talk about the new Gingivitis Code because I've been sharing it with our clients, but I wanted to get this message out. I know so many of you are curious and you have a lot of questions. So now's your opportunity to ask those questions. We'll allow you at the end of the webinar to answer any. We'll answer any and all of your questions. So if you're just joining us, please do have your handout downloaded and printed in front of you. I've got the bit.ly code up here so that you can see that and download it. I don't want you to miss out on gaining some great insight tonight from Roy and myself. What we're going to talk about tonight, I'm going to let Roy share with you what inspired these people, the ADA and the people who write these codes to spend so many hours writing a gingivitis code. I know I am a California hygienist, although I'm also an Oregon hygienist and live in Oregon right now. But I know the California hygienists for decades were trying to get a code for that patient who's more than a prophy, but not a pareo patient. So this is like a song, a hallelujah to those of us who've been waiting for this. And what is this new code? How do we use it? And then I'm going to show you some examples. I've actually been in an office where we were talking about this, and lo and behold, right after we had our meeting on the gingivitis code, there was a gingivitis patient. So I took some pictures and I want to share that with you tonight. So, Roy, explain to us, why do we even have the gingivitis code? How did that come to be?
Well, it wasn't easy. The Code Maintenance Committee is a committee that's made up of individuals representing the insurance industry and the dental industry. And until about 4 years ago, there was a court order that had lasted for 10 years that had established the makeup of the Code Maintenance Committee. And this committee is the one that is in charge of maintaining the dental codes. So prior to 4 years ago, the committee was made up of 6 representatives from the American Dental Association and 6 representatives from the dental insurance industry. So there were very few changes. Although the Dental Association, hygienists and dentists together, felt that there was a need for a code between a prophy and a periodontal maintenance, the insurance company resisted very vehemently that code. But 4 years ago, the court order that mandated the 6-6 makeup of that committee changed. The court order ended and it was revised, and the committee that resulted is now made up of far more dentists than there were insurance representatives. So being in attendance of these meetings, every year there had been submissions requesting various types of codes that should fill that gap between the two, but it was presented in a way that it was not palatable to both, so that they felt that it was an appropriate submission. And by the way, anybody could submit a code to the American Dental Association for consideration to be able to be adopted. If you Google request change to the code American Dental Association, it will take you to a website. There are forms and instructions how to fill that out. At any rate, 2.5 years ago, actually it came from a group of hygienists from California who made a submission that after 3 years of it being denied, the Dental Association and the insurance companies felt that it wasn't going to go away. So rather than pushing it under the rug again, they put together a committee made up of representatives from the Dental Association and from the insurance industry to nail down the new code. So they met immediately after the meeting and then virtually for the remainder of the 6 months, and they made a recommendation, and the code that we see today is a result of that meeting of the minds. They came together and determined that this would be the appropriate code to help describe, and it's very different in the way that it's written. It's very specific in terms of a diagnosis necessary. So it's changed in a way that it makes it very much more specific, and there's some reasons why those specific aspects of that code need to be addressed so that when submitting the code, it will have the greatest chance of being adopted. And by the way, the insurance companies were not in favor of this code at all either. I was actually at the National Association of Dental Plan meetings. That's a meeting where most of the dental insurance companies are represented. They come together kind of like the American Dental Association, but it's the insurance association. And they had a representative there who I attended the meeting. It was a code meeting from the insurance company's point of view. And that representative from the code committee announced that the group had in fact come together and put together this gingivitis treatment code. And there was a very noticeable grumble from the representatives during that committee. They were not happy that this happened. And the representative from the Dental Association Code Committee that represented the insurance industries followed that grumble by saying, and as a matter of fact, just because there is a code, it does not mean we have to reimburse it. So he was making it clear that just because there was a code, it did not mandate the fact that it needed to be reimbursed. We announced that to the insurance industry. So just to let you know, even though it is a code, is it embraced by the insurance industry? Not so much. So that's kind of a longer than necessary history of how the code came to be.
Well, I wanted to speak to that from the hygienist point of view, and that is we as hygienists see patients, and especially now with this economic decline, and it's still happening, all the economy, I believe, is turned around. But we are seeing patients all the time who are overdue, and they're more than a prophy. And, I know that there are so many hygienists over the many decades that I've been practicing in dentistry as a hygienist who were doing basically a pareo treatment non-surgically on patients and billing for a prophy. And so this is a code that helps us hygienists to get reimbursed for doing more than a prophy, but somebody who's less than a scaling and root planing patient, somebody who has pseudopockets and not radiographic bone loss, somebody who doesn't have 5 millimeter pocket depths. So I think that it's helpful for us to more accurately document what's really going on with our patient who's seated in the chair and they don't have a healthy mouth, which is the definition. When you look at that, the prophylaxis code, we're supposed to be working on somebody who's healthy, a healthy mouth, and yet there's this patient who's in between. They're not quite perfectly healthy and they're not active disease, you know. So this is where we're happy to see this. And there's good news. I hope that you guys will stay, because I'm going to share with you what's happening with our clients who are billing this, and how I ran this by, I always run everything by Roy as far as documentation and billing. I know, Roy, you've heard me go over and over and over some of these ways that we need to bill things. I'm always asking you. And so I have asked Roy numerous times how to bill so many different pareo procedures, and I'll tell you what our clients are doing now, and they are getting reimbursed. Not 100% of the insurance companies, but the money is being paid by insurance companies. So there's good news at the end of this webinar. I want to tell you about that. So Roy, do you want to tell them what is this gingivitis code? It's the D4346. You explain it to them.
Yeah, well, I want to address first something that you mentioned as far as being able to use the code to document appropriately. You're absolutely right. A prophy code is a preventive code, one that would suggest that we're preventing disease. And we do see patients who come in very frequently who have inflammation, and that's not a healthy mouth. So using a prophy code to describe that would suggest that the prophy is to prevent disease. We needed a code to describe the treatment of a different type of situation that may not be to the level of periodontal treatment, but it needed to be described otherwise. So yeah, that's a great point that you made. I'm glad that you made that, and it's good that you dissect the nomenclature and the modifier of the codes. The nomenclature after the code, the 4346, anything that's in the dark when you're looking at the ADA codes, that is the nomenclature, and then the descriptor is any information that comes afterward. And anytime there's a question about the code, it's always great first to look at how it's written, how it is supported by the other information. So 4346, scaling in the presence of generalized, and let's be specific about generalized. From definition from the ADA, when they discussed the code, the question was asked, what is considered generalized? And that is any time there is 50% of the mouth or greater that's affected by the disease. So there again, when you're making your diagnosis prior to the treatment, and any treatment that's provided to treat a situation needs to have a definite diagnosis prior to. And I'm going to drop back a little bit and let's get basic here in terms of the variables necessary to be able to adequately give a diagnosis for a periodontal or a gingival condition. It's either mild, moderate, or severe. That's one group of variables. It's chronic or acute, another set of variables, or it's generalized or localized. So it's mild, moderate, severe, localized, generalized, chronic, or acute. So a complete diagnosis for either periodontal disease. Periodontal disease would be something like chronic, severe, generalized periodontal disease. That's a complete diagnosis. Gingivitis, the same thing. It is chronic, generalized, moderate gingivitis. So this is very specific about the necessity for a diagnosis prior to treatment. So the diagnosis in this situation needs to be generalized, moderate, or severe gingival inflammation. Very specific in that diagnosis. It doesn't have to indicate whether it's chronic or acute for it to be able to qualify for reimbursement as far as the coding piece goes, but for the reimbursement, the clinical record should contain a diagnosis that states there is generalized, moderate, or severe gingival inflammation. And this is scaling of the full mouth, so it's not a quadrant code like the 4341 or 4342. And it's after an oral evaluation. We'll talk a little bit about the debridement or debridement, depending on how you want to pronounce it. And the evaluation part is very important in the use of a debridement code. So this is a situation where a patient comes in with inflammation, generalized moderate or severe inflammation, and it's determined after the oral evaluation. They wanted to make it very specific that an evaluation is done prior to. And the system, the service includes the removal of plaque, calculus, stains from super and subgingival root or tooth surfaces. And if there's no bone loss, there again, it doesn't say root surfaces. So for there to be access to the root, it would be suggested that there is some kind of periodontal disease. There's attachment loss and bone loss. So this is subgingival and supragingival surfaces when there is generalized, moderate, or severe gingival inflammation in the absence of periodontitis. There again, no bone loss. And that is one of the biggest determining factors. You can have pocketing here, especially if the patient is in bad condition. You can get a lot of pseudopockets, a lot of swollen gingiva. So you may very well have pockets of 6 millimeters or greater, lots of bleeding, but the differentiator is the bone loss. So if there's no bone loss, can you get to the root to scale? Probably not. Healthy bone without loss is going to be at or near the CEJ, or within very, very short distance from. So as far as root planing in a mouth that has not had bone loss, that would not be possible. And it's indicated with patients who have swollen, inflamed gingiva. So what would be the best way to document swollen, inflamed gingiva? Will that show up on a radiograph? No, it will not. Best way to document that and to be able to support the need for treatment would be with an intraoral photograph. Those are very valuable and, in my opinion, necessary for the processors of the claim to determine that, in fact, there is swollen, inflamed gingiva, because that's not going to show up on a radiograph. You can indicate that in your charting as far as that goes. There again, you have to be specific, but a picture is very, very revealing and as to the situation that's observed. So generalized suprabony pockets, like I said, above the bone. If the bone has not been resorbed by the disease, it's going to be suprabony. And moderate to severe bleeding on probing. There again, you're going to need to be very particular about your charting so that it does indicate the bleeding points. There again, photographs are great to be able to take. In fact, you can take photos with a periodontal probe in position with, it can show the pocket depth as well as bleeding if it's there. Also very good to be able to support that. Should not be reported in conjunction with a prophy. So prophy scaling or root planing or debridement procedure. So it is an independent service. It does include the whole mouth, and it should not be done or submitted with a prophylaxis, because you're going to do a prophy as a part of this scaling and removal of plaque calculus and supragingival stains, like the descriptor explains, or the debridement procedures. Like I said, it's very specific about it is a independent standalone type procedure that is not included with, or may include, the scaling prophylaxis. Root planing is not done because there are no roots exposed, and the debridement procedures are in situations where there is an inability to be able to do an evaluation. That's a mouthful. I don't think I took a breath during the whole time. I'm sorry.
A lot of information, but we'll actually recap this again towards the end. We've got we'll go over it again because I want to be real specific and, kind of bullet point this big paragraph. So okay. Bottom line, is it appropriate for a difficult prophy patient? Remember, I was talking about that patient who's overdue and we were just scaling away. They maybe need to have some parotherapy. Maybe they were coming back for 2 prophy appointments. So what do we do in this situation? The answer
is it appropriate for a difficult prophy patient? If the patient has generalized moderate to severe inflammation, the answer would be absolutely yes. If you cannot diagnose the patient using those terms, then no.
So I hope if that's not clear, send us a message and we can talk about it again. I just want to make sure that everybody's clear on how to use that, because we have a new way. We have a new way of helping ourselves to get our patients healthy, to make sure that they're healthy, instead of doing our very best and sending them on the way for another 6 months. So I wanted to share with you, this is a patient that I would consider a gingivitis patient. You can see here what's going on. This is what Roy was explaining. And Roy, can you speak to this patient here? This is what is called plaque-induced gingivitis.
Sure. As the group, is it generally hygienists that you're speaking to here, Debbie?
We actually do have some doctors on the line, Roy.
Okay. Same for both as far as that goes. I didn't know if you had any business people on that may need a little bit less technical. But plaque-induced gingivitis, the plaque, of course, the bacteria produce toxins, acids, all kinds of negative secretions that irritate the tissue. And if left in place for a long period of time, it causes inflammation. It's a reaction to, there's swelling, and the tissue becomes unhealthy. It's friable. In some cases, if you just touch it, it's going to bleed. You can see there how the red touches the margins of the teeth, and the plaque, you can see without disclosure that there's a huge amount there. This is, I would consider, moderate to severe gingivitis. Certainly it needs something greater than prophy to prevent disease. There's obviously a disease process going on here, and therefore this code would be an appropriate descriptor for the service to be able to remove all the concretions and the plaque and the buildup on these teeth.
Mm-hmm. And this is that patient where they would come in, and we would, well, I know from my point of view, what we would do is we see a lot of plaque around the gum line. We would probably take the prophy angle and some polish and polish off all that plaque, and then use the ultrasonic and some scaling. I mean, some of us would probably in the past put them on to 6 months because that's what they were always on, was 6 months, but they were a little bit overdue. So now we're treating this different, and it's like an answer to our prayer from hygienist's point of view. This is another one, and this one is red, swollen tissue, not as bad as the other one, but still non-plaque. This is non-plaque induced gingivitis. So similar to what we saw, but not as much plaque. And I just wanted to share with you, this one here is a patient, when we look at the radiographs, we do have some moderate gingivitis here, probably some occlusion issues on this patient here. So this would not fall into that category. And the other question is there a waiting period between completion of that D4346 and then the delivery of your prophylaxis as part of the patient's routine preventive regimen? And Roy, can you speak to that answer?
Well, first I want to preface that by saying I highly recommend that you never put together a treatment plan and recommendations to a patient based on the reimbursement for. It's going to vary according to that patient's need. In terms of the waiting period for the reimbursement, it will be similar to limitations to a prophy. It's a little early. It's only been a code that we could use since January 1st, so it hasn't even been 3 months yet. But the feedback I've gotten from most of the dental directors from the insurance carriers, they're going to limit both the reimbursement as far as the amount and the frequency to the regular prophy. So if the 4346 is done in January, they probably will not reimburse a prophy subsequent to that until July, but because of the frequency limitations. But there again, in a case like this, I would very strongly recommend that the patient come back before that, especially in the cases that we saw that you represented. It's going to be important that you bring the patient back to find out, number one, are they being more compliant, encourage them to continue with the home health care, and to provide any follow-up that might be necessary at that point.
Yes.
Be a good idea to find out if the tissues have resolved. The pockets, most of the time, if pseudo pockets resolve very rapidly, if the hygiene improves and the irritants are removed.
And the way that I think of it is, it's like a non-surgical procedure. I mean, there's inflammation. And so if we have a medical condition where there's inflammation, and we know that it's a disease process that could be around the corner, wouldn't the medical professional have you back for like a post-operative visit? And that's how I think of it, as a post-operative visit. Depending on the patient's risk factors, it could be that they need to come back in 6 months, like if they're using tobacco, if they're type 1 diabetes. For me, my personal opinion is that I believe they should come back in about 6 weeks to make sure that things are healing. Now, Roy and I were talking about this in preparation for this tonight, and it's like they come back and it's not a full hour with the hygienist, but they can at least come back for a post-operative visit to make sure that the inflammation has healed, that their home care has improved, and we're not just sending them on their way. In 6 months we see them later like we used to do in the good old days. So I just wanted to mention that.
And as far as from a revenue point of view, this may very well be a situation when the patient comes back more frequently that carriers would consider it an optional service. And there are steps that you can go through to have it approved that although the insurance isn't going to pay for it, the patient will be responsible for the additional visits, and it would be paid out of pocket there. Again, you need to explore with the insurance carrier their position on optional services, and you need to have the patient be made aware prior to providing the service that they're going to be responsible for. So there are steps that you can go through to be able to have the patient responsible for the additional services that they need to be able to get to a point where they're healthy and able to be maintained on what's considered a more normal 6-month schedule.
Mm-hmm. And I think that it's really important that this is a whole nother webinar that we can do another time, Roy, but our patients need to understand, and we need to educate them on what is dental insurance. What does that mean? It doesn't mean that they pay for everything A to Z, just like, and I'll make it real short here because this is not a webinar on insurance reimbursement, but they're getting benefits, a benefit package from their employer. And when they get vacation pay or paid days off, that does not include the airfare to Hawaii and the hotel and food on the paid vacation while they're gone. They get those days paid. They get a 401k, that's part of their benefit package. And they don't get the retirement home and, the Medicaid and, Medicare, all paid for. So people need to understand that. Like, I just got a bill today. I got my mail before starting the webinar, and I got a bill for some lab fees, some blood tests that I had run. And I knew that was going to happen. I have great insurance, but they don't pay 100% of it. And we have to just educate our patients on this so that they understand that we're doing what's in their best interest so that they will live a longer, healthier life. Because when they walk around with this type of inflammation in their mouth, it actually transfers into their body and causes other systemic diseases. So that's a whole nother webinar, but it is our message. I believe my message, why I do what I do, is to help people throughout the world to live a longer, healthier life. And I hope that's your message as well, as we're all together here on this webinar as dental healthcare professionals. May the oral evaluation and the D4346 be performed on the same date of service? You did mention about the oral evaluation that needs to be made first. So Roy, can you speak to that a little bit more?
Yeah, it not only may, it has to be by the definition of the code. So there needs to be evaluation beforehand, and that evaluation should yield that diagnosis that we talked about when we first discussed the code. So may it should say must the oral evaluation and the 4346 procedure be performed the same day. Not necessarily on the same day, but an oral evaluation has to occur prior to providing the 4346, and generally in a short period, either the same day or a short period ahead of, and that could be a 150 or a 120.
Yeah, so it's not going to be the D0180.
It would not be, because by definition that's a pareo patient, and you've already determined this isn't periodontal disease, it is inflammation, it's gingivitis.
Thank you. So what is the clear and accepted definition of generalized moderate to severe gingival inflammation? so that the 4346 procedure can be differentiated from the prophylaxis procedures.
So that we, as we discussed before, at least half the mouth should be affected by the inflammation.
So at least 50% of the mouth has that. Okay, thank you.
Yeah.
And let's see. And what procedure is appropriate for patients with localized gingival inflammation, gingivitis?
Or it can either be mild, generalized. Either of those, the prophylaxis would be the appropriate code to describe that. So neither of those situations where it is localized or whether it is mild, it's not to the level that the 4346 would be the code to describe it. Both those would be described using the prophy code.
Awesome. And then, oh, somebody did ask this question as well, and here it is again. Is this a full mouth procedure? Does this mean that it's completed? The 4346 is just one appointment completed in one day.
That's a great question. It is a full mouth procedure, so the 4346 would be the treatment of the entire mouth. Does it have to be completed on a single day? It does not. It should be billed out on the day that it is completed. Does not need to be completed on the same day. So it could be a multi-day procedure, but it's a single code that describes the entire treatment of the mouth from both arches, all four quadrants.
So we have a lot of questions coming in right now, Roy, and I'm going to address these at the end because some of these people, I don't know if their questions are getting answered. I know it might be kind of confusing even though we're going over it. We've gone over some of these a couple of times. So we'll talk again at the end, and I'll let those people who have questions be unmuted so that we can make sure that they're clear on these answers that you're giving.
Great.
What should be documented with the patients, with their record to support the delivery of this? So let's talk about documentation because, Roy, I know that you're the expert. I always go to you. And, when I saw this for the first time, I knew about the Gingivitis Code. I was so excited the first time I was in an office and we saw the patient with this Gingivitis Code. So,
you're a sick individual.
I'm so excited. I'm going to show everybody the pictures.
I don't know I would have put it that way. I would have been disappointed, but that's just me.
Oh, I was like, oh my gosh, I can talk to my people about this, and share this with the world. So I'm going to show you the pictures of that poor patient who will remain anonymous. But what we did was we took some intraoral photos and I wanted to share them with everybody tonight to show them. But one of the things that we didn't say, and I recommended to my office, my client, that they send in the pareo chart. So we had the pictures and the pareo chart, and you'll see one of the pictures does have the probe, which is what, it's the probe showing that it was a 3mm pocket. And we took various photographs of this moderate to severe. I mean, every tooth had this gingivitis, just a lot of swelling around each tooth individually. So Roy, do you have anything in addition to add to this documentation?
Yeah, it's a great point that you make as far as the probing or the periodontal chart should be included. So that should include the pocketing and probing depths and bleeding point, because bleeding is there again an indicator of the inflammation, and the number of sites that bleed would also be an indicator of the severity and whether or not it's localized or generalized. Good. And like we said, the photos that you had mentioned also excellent. When somebody looks at them, when you have a gingivitis case that would be treatable, it would be considered moderate to severe. It's pretty evident on a photo. Like I said, it may not be so evident on a radiograph because it doesn't give us a view of soft tissues. And there again, the pictures are going to be important. I just want to back up just a little bit. You showed a Panorex of an individual that was taken. Standard of care for a periodontal patient or a new patient, depending on their risk situation, would be a full mouth series. It wouldn't be a Panorex instead of bite wings. Just going to throw that out there. Anybody interested in a reference regarding radiographs? The ADA and the FDA in 2008, it was updated in 2012, put together a document that outlines the necessity for radiographs, and it also gives a grid according to the risk and the age of the patient. And in that box that's associated with that particular patient, it's going to make suggestions as to what is considered standard of care in terms of radiographs. So if anybody wants a copy of that, Debbie, I'll be happy to forward you a copy if you want to distribute to the
Thank
people who
you.
want that.
Yes.
Yeah, I'd be happy to.
I will do that. Thank you so much. That is a key point because I have so many clients that are doing just the Panorax and considering that they're full mouth series. So thank you for that clarification. I need to I need to get on them about that. Thank you.
Yeah, if anybody who's on the webinar has some issue with getting their scaling and root planings approved, if you've documented with a Panorax and bite wings, that's probably one of the reasons why it could have been denied, because those aren't considered standard of care in terms of treatment for a periodontal issue, and that would be a case where scaling and root planing would be necessary or periodontal surgery. So protocols would indicate more than likely that a full mouth series would be necessary for them to be able to review and approve that treatment.
Oh, that was great information. We just got a bonus on that one. Thank you.
Oh, that's just more of nothing, I guess.
Now, let's just really make sure we cover this thoroughly. Is the D4346 a procedure followed by pareo maintenance, or can it be reported with pareo maintenance? I know this is repetitive, but I just want to make sure that we're all clear on this.
The answer is no. 4346 is to treat gingivitis inflammation, and by definition, it's not periodontal. It's not, the patient doesn't have a periodontal condition. Technically, it's considered gingivitis, not a periodontal disease process. In periodontal maintenance, 4910 follows scaling and root planing or periodontal surgery. So it would not be appropriate to report a 4910 following unless the patient did continue to get worse and required scaling and root planing or periodontal surgery. And after that point, it would be appropriate to report the 4910 as maintenance after the fact.
Mm-hmm. But I mean, how likely is it that somebody comes in for the D4346? I mean, we've seen those pictures just a few minutes ago. And that type of patient, what we're saying is that they would probably come back 6 weeks, depending on the risk factors, maybe definitely 3 months after this 4346 procedure is completed. And how likely would that be that now they have bone loss and that they become a scaling and root planing patient?
Well, it depends on the patient, of course, and the risk factors. A smoker or diabetic could very well, that could happen, or a patient who becomes or continues to be non-compliant, could they proceed to a point where they would be scaling and root planing or periodontal maintenance? Could be. There again, our hope is that they adhere to our recommendations and that they follow protocol and take care of things. And in that event, the chances of them getting to be healthier are much greater. So could it happen? It could. Is it likely? Unlikely, unless, like I said, there were some contributing factors that would maintain situations so that they did get worse instead of better.
I think this is where we want to spend that time with the patient. We're doing the diagnostics, making the diagnosis, and that should come from the assistant, the doctor, and talking about the contributing factors to, actual gum disease. That's what I say to our patients is gum disease because they don't understand periodontal. But it's actually having that conversation with them and hopes that they take it seriously.
Yeah, I would even break it down a little bit more basically to the patient. I would sit them up and go, you've got an infection in your gums, and that infection is caused by bacteria. And to be honest with you, we're seeing what's happening on the outside. What you're not seeing is that same bacteria that is causing your gums to look like this is also inside your body, inside your bloodstream, and can be making your blood vessels in your heart just as inflamed, especially if they attach there. So this is a severe condition. I don't care if it's just gingivitis or if it's periodontal disease. Bacteria is the same, and the chance and the risk of it becoming systemic is just as great. So I would sit them up, neat and eye and say, hey, you've got an infection in your gums, and I'm very concerned.
Yeah, yeah. And, this is what we're teaching with our clients, this piece right here. And you're going to start hearing about this in, CE courses more and more, and the Bell-Donine method. I don't know if anybody on the webinar has heard of that, but Dr. Tom Larkins and Bell-Donine, when you're talking in these seminars with these people, what they're saying is why patients are coming back to their hygienist and their dentist is because they understand that this is affecting their total health. That's when you get compliance with your patients. Number one, of course, it's building rapport and they have a great relationship. They're not just another mouth seated in your chair, but when they understand that you're helping them to live a healthier life and a longer life, they say this is where compliance really comes in. And that's when you're going to see less holes in your schedule, is when patients really understand that you're helping them with their total health.
Can I take that one step forward,
Please.
further, Debbie?
Yes.
If the staff has been good, if the hygienist has been good about documenting the specific inflammation in areas, so when that patient who is due to come in 4 months or 3 months or whatever the schedule has been determined is appropriate for that patient, and they call and say, I need to cancel my appointment, it's just a cleaning, the person at the front desk should open that clinical record and say, not so much. I notice here in the record you had some severe inflammation in your tissues, and the doctor was concerned about the bacteria and the fact that it might be becoming systemic, and that we needed to keep an eye on that to make sure that it doesn't continue to grow or develop into periodontal disease that may need some surgery to treat. That patient is going to be very less likely, in my opinion, to cancel that appointment or to postpone it if they understand there is a very active disease process that could affect them very dramatically if they don't continue to take care of it and follow instructions as directed.
Oh my gosh, Roy, you've never been my client, but I'm so glad you said that, because we have some clients, they couldn't attend the webinar, so they registered, and I'm going to send this to them. And this is exactly what we teach. And it's called an R2R. It's a reason to return. And it's documented in the patient's record. And we teach our client offices that when somebody calls, they cannot just reschedule them. They have to say, may I please put you on a small hold, a short hold. I need to check your patient record. And then when they come back, we actually write this out. We have a whole system around these steps, exactly what you were talking about, Roy. So thank you so much. They're going to be listening to us later, and they'll hear you, a doctor, said this. Thank you.
You're very welcome. You stole that from me, right?
Yes, I've been your client for years.
I'm kidding.
The D6081, scaling and debridement in presence of inflammation or mucositis of a single implant, including cleaning of the implant surfaces without flap. Can this D6081 and the D4346 be delivered to the patient on the same day? Now we're talking about an implant here, and then they've got the gingivitis.
Oh, absolutely. Yeah, they can. And be aware that the 6081, if the patient has multiple implants, it is a per mouth code as well. So it's, it's for a single implant. It doesn't include the entire mouth. So each single implant, if the patient has 5 and they have the inflammation around 3 of them, you submit it 3 times for each of the 3 implants that it is affecting, and it would be in addition to the 4346. Unfortunately, as far as your reimbursement goes, it would be unlikely that they're going to pay for both. And there again, if you do a 6081 in conjunction with a regular prophy or a 4910, most insurance companies will not pay both on the same day. And there again, this might be an opportunity to be able to discuss optional services with the patient. And if I can back up just a little bit,
sure,
too, in terms of that patient who needs the 4346, the scaling with the inflammation, I would quote the fee to the patient for the entire treatment for the year. And I would describe to them, I would explain to them that your insurance company will only cover what's considered a healthy mouth and 2 cleanings, regular cleanings a year. They will pay that portion toward the treatment of the inflammation that we've diagnosed and are recommending to you. That would not be out of pocket, but the additional treatment that's over and beyond what is considered a normal cleaning, that would be an out-of-pocket expense.
Okay, thank you.
You're welcome.
We got another bonus point there on the 6081. That was great information you just gave us. Let's talk about this gingivitis patient and the series of appointments. And I see a question on this. So the patient has inflammation. It's moderate to severe. We saw a lot of plaque. They could have some calculus, mainly supracalculus. They've got a lot of bleeding. 3, maybe some 4 millimeter pockets. Light to, oh, this patient here, I wrote this down. Light to moderate gingivitis. Maybe there's some areas of light, but 50% is moderate, and there's no bone loss. So what does that look like? I think that if that patient is a type 1 diabetes patient, I recommend that they come back 6 weeks later. And there's a question somebody wrote about this, Roy. Why 6 weeks?
There again, it's not set in stone. It would depend on the patient and your assessment. What would be an appropriate time to be able to bring that patient back? That might be too long. If you have a patient that is very severe, if they're not moderate, in this case, just to backpedal just a little bit, I'd be careful with documentation of this type, although it's good. If it says light to moderate gingivitis with no bone loss, if this is the entry into the clinical record, it doesn't specify. This could be confusion. It could be not considered generalized. So you need to be, I would be specific about the percentage that was light and the percentage that was moderate. So it would be considered generalized. Okay.
Good. Thank you very much. So
you're welcome.
I think we need to say like 50% moderate gingivitis, or, only the, 6 through 11 was light gingivitis, or something, to that effect.
Yeah, you would, that would be specific in the, more than likely in the periodontal charting.
Mm-hmm.
So there again, you can use that to kind of refer to and be able to build your clinical record based on what you find there. And you can do, it's easy to kind of do the math, counting the number of teeth and the number of areas you're having bleeding and what's considered moderate. But yeah, as far as the timing, nothing is set in stone. Just like your periodontal patients, there's some that you're going to need to see more frequently. There's some that you need to see less frequently. And there again, it would be based on that patient's needs. So don't take anything that we've suggested as the gospel. It needs to be done that way. There again, it needs to be a decision made with the hygienist, doctor, and the patient, determining which would be the most appropriate interval for them to be able to be properly treated. And there again, we're talking about treating the disease process, not the reimbursement. We're not treating the patient's insurance, we're treating the patient. So anything you do should be based on that patient's need and to maximize their healing and their health afterward.
So the reason why I said 6 weeks for that post-op is because when you look at the epithelium and how long it takes for that to be healed, it's usually about 28 days. And somebody with diabetes, somebody who's using tobacco, their healing process is going to be longer than somebody like you and I were healthy. So that's why I arbitrarily said 6 weeks.
No, that's fine. There again, based on that clinical information, you could also base it on what you would consider patient compliance. So that patient you're thinking is not going to be very compliant, you want to kind of encourage them more frequently to maintain their home health care. You might bring them in at 2 weeks or 3 weeks just to kind of get them in a chair, check how they're taking care of their teeth. You may not necessarily have to treat anything. You can evaluate, of course, but you might go over the oral hygiene again just to make sure that they are hitting all the spots that they need to be able to maintain their health.
Mm-hmm. Now, Roy, you brought up a really great point, and this is what we're doing with our clients. Instead of saying that today is $56 or today is $120, what we're doing is saying that your hygiene appointments, and you said for the year, are going to be, and by the way, that is not, our friends at Care Credit say not to discuss this with the patient in the chair with the bib on. I suggest that the cost be treatment planned. I mean, this all needs to be treatment planned, and then you speak to the financial coordinator who talks about the money. That's how we teach
Yeah,
it.
and I would make it based on the treatment of the disease. Patients, they don't understand the bits and pieces of, they want to know what it's going to take to get them healthy.
Yes.
And, it would be, this is the overall cost. This is what we expect your insurance to cover of that. And this is what we are anticipating as far as the number of visits that we are anticipating that you're going to need. You can break it down piece by piece, but to me that, in my experience, it confuses the patients. They want to know, okay, don't dollar and cents me to death. Tell me what it's going to be able to treat my disease and get me healthy.
So I
You
thought
know,
it was, yeah, that was great what you said about let's do the annual. Like, this is our annual plan for you.
yeah.
I really like
And
that.
yeah, your prophy code has an extra zero in it.
Oh, D0, what, it should be 1110.
Yeah,
Thank you.
you're welcome. I started to say that looks more like a medical code, but that's not.
You can tell I'm not the coding expert you are.
No worries. So it'd be gingivitis code first, second appointment, and subsequent appointments would be prophies, unless that patient did go south. If it did get worse and it needs scaling and root planing, is that a potential subsequent appointment? It might be, yes.
And so, Roy, in this situation, let's say that we are estimating the patient's going to have the gingivitis code. They'll come back maybe, let's just say this patient comes back 6 months later and we're going to do the prophylaxis.
Okay.
So we're going to tell them, we estimate that this year it's going to be. And so how would we break this down? Because we have a question like the gingivitis code. I can tell you what our clients, we talked about this, Roy, yesterday, you and I, but let's share with these people on the webinar, what is a good general fee range that offices are going to charge for this patient? Let's just talk about the gingivitis and the prophy.
Okay.
Those.
What we're seeing and what we're recommending is somewhere between 1.5 and 2 times the prophy code fee.
So let's say that your prophy is $90.
Okay.
What I have been seeing reimbursed so far in that situation is 120 for the gingivitis.
And are they paying it at 100% or 80% or 50?
80%.
Okay. Because it is in a pareo code set. It's a 4,000, and a lot of times if it's in a pareo code set, they're not going to pay 100%.
Correct. Correct.
I'm curious. Yeah.
Yeah. So the billing
here on the East
has,
Coast, we're not seeing.
Yeah.
Here on the East Coast, we're actually seeing it being remapped to the prophy code, especially in the beginning. Insurance companies have already sold those plans to their employers, and those plans were specifically designed with a set number of codes. So several of those plans have limitations that say they will not pay for anything additional, and they would reevaluate when that contract was renegotiated so that it might adopt that as payment. So we're seeing it kind of all over the board in terms of the reimbursement. And it might be a good idea, if you wanted to, just to poll the people who are listening if they've actually submitted the code and their experience in reimbursement. It would be interesting to hear that.
Oh my gosh, that is a great. Let's see if you guys can please post in the chat box. Just let us know, have you submitted for this? Yes. And then again, second question is, have you been reimbursed? And then the third one is, what percentage? Was it 100% of your normal fee? So number one, some people are saying, yes, they have billed for it. Have you received, my next question to you is, have you received payment for that? And then what did that payment look like? Was it 100%, 50% of your, and they have it, some of them are saying that it was down, 80% downgraded to a prophy fee. So some have not even received payment. It says that the majority of people looks like they haven't received payment yet. But my offices, my clients have received payment. yeah, so I don't know if I should go into detail anymore on that, but yeah, they are. I know my clients are receiving payment. We started
Right.
right away in
You know, I
January.
mentioned to you the other evening that we're finding that it's either not being paid at all or it's being remapped to a prophy code.
Mm-hmm. Luckily, on the West Coast, we have seen it be good reimbursement. Higher than a prophy. The
Right.
ones that I've
Good to know.
Yeah. So this is that patient I was so excited about because I'm sick. I love the pareo patients, but this is a patient that came into one of my client offices. And it was the first time that I actually got to be in an office this year and see a gingivitis patient. So we actually used the intraoral camera to take these, and we submitted these pictures with the insurance billing, along with the also the pareo chart as well. So you can see we also took a picture here of the pareo probe, and you can see that's definitely not more than a 4 millimeter pocket there. So yeah, it was a very young lady, 22 years of age. She was a blonde, blue-eyed, all-American looking young lady, college student. And this is how she presented. She had an extraction the week before on a lower molar, and she wasn't brushing well, but gosh, this is more than not brushing well for a week. It's longer than a week that she wasn't brushing these teeth.
She's
So
smoking or diabetic?
she is not, and that's one of the things we were thinking about this. I was asking Roy last night, I'm like, what would you do? I mean, to me, 22 years old, and I feel like what I saw visually doesn't look as profound as what I saw with my eyes. But then I have my loops on too, so maybe that blew it up. But it looked a lot worse than what I see in these pictures here. And I was asking Roy, I'm saying, Roy, what do you think could be going on? And this is the type of patient where I would suggest that they have a physical with some blood work, because I mean, we were actually thinking, is she bulimic? Does she have diabetes? There's something going on here versus not just toothbrushing. This is where we talk about the total health and
Right.
educating our patients about that. So this is what is not considered a gingivitis patient. This patient is a very severe, aggressive bone loss, and probably some pareo therapy, but some extractions, and then seeing a periodontist. So just some more aggressive pareo problems. So let's talk, Roy, about how does this relate to a pareo program?
Well, it would be an integral part of, there was a whole class of patient that we were forced to use a prophy code to be able to describe when there was moderate inflammation, generalized. So it's going to be an integral part of the descriptor of the situation when the patient presents. And in those situations where you find that, in fact, the insurance is not going to consider or pay that, bill for what you do. That would be using the 4346, but ask for the alternate benefit of the prophy. You bill for using the appropriate code, and you ask for what might be reimbursed. And especially in those situations where they say they're not going to pay for it at all, I would certainly make a plea to have at least the prophy be paid, because you are certainly due something for providing the work. It may not be adequate to compensate for the extra work that was done, but certainly something's better than nothing. So there again, the patient that comes in without bone loss with a lot of inflammation, this is the describer. The patients that have mild or localized inflammation, that's going to be the regular prophy to describe that. Is this an appropriate time to start to talk about the debridement, the 4355?
Well, they're not a patient that's set up for 4355 at this point
Okay,
when they have gingivitis.
correct. Well, maybe. The 4355 would be for the patient that comes in and has so much buildup you can't get a evaluation done. You can do everything as a part of the evaluation except the periodontal diagnosis. So there are cases when patients come in with so much calculus and tartar that you can't get a probe in position to be able to get a accurate probing depths. And that code specifically states that it's the 4355 is done in order to be able to complete an evaluation, and the assumption there is the evaluation is going to be a subsequent appointment. So the debridement would be done, and then the patient would come back at a period, maybe a couple of weeks afterward, when the tissues had resolved, and you could actually get a periodontal diagnosis. And that patient may actually be a prophy patient afterward, or a 43, 46. It could be an inflammation appointment, a patient, or it could be a pareo patient. So it's a little bit different, and the discrete determiner is whether or not you can actually get an accurate diagnosis of the periodontal condition at that initial appointment. So, and that's one of the reasons why they had added the part after an evaluation in the descriptor of the 4346. That makes sense?
Yeah. So
okay.
The step one, the first step is to make a diagnosis.
Or attempt to.
At least, yes. And if you can't make the diagnosis, then you'll go to the 4355.
Correct. If you've debrided the tissue at that appointment. And like I said, you can complete all the other components of the evaluation. You can do a TMJ evaluation. You can do oral cancer screening. You can evaluate the radiographs. You can do everything except get your periodontal diagnosis. And you should only bill for a service, in most cases, depending on what the incurred liability date, you can only bill for a service once it's completed. So you'd bring the patient back and complete the evaluation at a subsequent appointment and bill out the evaluation at that appointment.
So one of the things that I wanted to mention is when the patient comes in and they're outside of a prophylaxis patient, they don't look completely healthy, how this relates to a perio program, in my eyes, as from speaking from the hygiene point of view, is this is a chance for us to talk about their responsibility, their, future, the risks of not doing anything, the risks of not taking this seriously, that it's not just we're going to put a Band-Aid on this and you're going to come in today and be done with it. No, this is something where it actually can affect their total health. And that's where the conversation begins, is when we know we have that diagnosis and we're doing a 4355 and we're doing a comprehensive perio evaluation, which, by the way, when I start working with a client, I always see this one inefficiency, and that is a lack of billing and a lack of knowledge on how to bill the comprehensive perio evaluation, the D0180. It's across the board, Roy. I see that they haven't been billing that, and people don't know how to use that. So that's what we do, is help you. And I have gone over and over and over with this with Roy on how to bill that perio therapy, that perio program correctly, so that your patients do get reimbursed for it, or you get reimbursed for it. Anything to add on that, Roy?
No, just to highlight the protocol for a 180, a periodontal, comprehensive periodontal evaluation, that would be when you have a periodontal patient, there is periodontal disease, or you have a patient that is higher risk, that would be a diabetic or smoker, for example, or a higher risk for periodontal disease. The only thing that's different from the 180 and the 150, number one, the patient has to be a perio patient and have a greater risk of, and it mandates, it doesn't say if indicated, it mandates that the full perio charting is done. So if you have a perio patient in your chair and you do full charting, then would it be appropriate to bill the 180? Yes, it would be. Most insurance companies will allow the 180 to be reimbursed on a limited basis. Most will not allow you payment each time. They'll remap it to a 120 in most cases, if it's beyond what's considered the limitation period. But if you don't ask for it, you don't get it, and always bill what's appropriate. That would be the appropriate code to describe that. Patient who has gingivitis, unless they have contributing factors, even though you may do a full periodontal charting, that would not be a 180, that would be a 120, or a new patient would be a 150.
But in the case of that one patient I mentioned with type 1 diabetes and the Gingivitis Code, can we do a D0180?
You may. It's going to be very important that the documentation includes the fact that the patient is diabetic and at higher risk of periodontal disease.
There you go. So that's going to be part of the notation. when you're billing the insurance. Roy, how do we differentiate the scaling procedure from the current debridement procedure? I know you just talked about that a little bit. So they come in and they have the let's say they come in and they have the D0150, is that right? And then the D4355, the gross debridement.
No, you wouldn't do a 150 at that appointment there. Again, the evaluation can't be done at that appointment. Now, that might be submitted once you do the debridement and bring the patient back. Okay. Second appointment, the 150.
Okay, so when they come back, so that day they came in, they had a full series of x-rays. Then the doctor diagnoses that they have a potential pareo problem, and to get a real good reading on the pareo, they need to do the 4355. So they go over to the hygienist and do 4355.
Yeah, the doctor could, or the hygienist could do a quick eval and determine that they're not going to be able to get good probing depths, and they're not going to be able to get a full diagnosis, whether that be pareo or gingivitis. At this point, you can't diagnose, so you don't know. So the criterion for the 4355 is that patient that comes in with a huge amount of buildup, and it inhibits the ability to get the information you need to get to the diagnosis piece. So you do the debridement and then bring the patient back, and at that point you should be able to do the necessary probing and to be able to diagnose appropriately the periodontal or gingival condition at that point. And it wouldn't necessarily have to be a perio patient. It could be a prophy patient once they come back.
Okay. And then with that prophy patient, is that because they were a new patient with an FMX, would we do the 150 code?
At the subsequent appointment, yes, if it's a new patient.
Okay. All right. Thank you for that clarification. That was great.
You're welcome. Yep.
So let's talk. So we talked about those exam codes, and I know that we're going over our hour with you, and people are getting antsy. So if you have more questions on the exam codes, just write them in the chat box, because we do have a lot of questions. And then as far as the oral evaluation, we have covered that, I think. So if you still have that question, go ahead. I want to thank you for staying with us this long. It's just a little bit over the hour. If you want more, this year, Dental Practice Solutions, Dental Hygiene Solutions, I would call it, powered by Dental Practice Solutions, which I started 17 years ago. We are back doing a lot of CE courses. They're live courses. You can see we have a photo booth there. We have lots of food for you. You get 6 CEs. We always have special pricing at the very beginning. So right now, we're having a jump start, and it's to get your dental success plan in place. Without a plan, you have plan to fail. That's what I say. So I wanted to invite you to join us for this. It's happening in Portland, Oregon, March 10th. And then in June, beautiful San Diego on June 23rd. It's the business side of dentistry, your game plan for success. And I'm going to be doing this course with Doug Fettig of Aldrich. They are dental CPAs, and they're here in Portland, Oregon, and they have offices in San Diego as well as other places in the U.S. But again, we're going to have the photo booth and a continental breakfast, lunch. Our sponsors have prizes for you. The prizes range from Starbucks cards that are $5 all the way up to, we have one gift that we're giving away that's $1,200. So there's just, everybody ends up a winner when they come. I mean, we're just giving prizes out throughout the day. Like every half hour, we're giving prizes. If you want to know more and talk to us more, I know, Roy, we have so many people on here that called our office and said they're thinking about working with us. So I want to let you know, if you're looking at somebody who can be an advocate for your team, somebody who can be running by these types of team meetings for your team, you can contact Vanessa, and here's her number. At this point, I'm going to leave this up there if you're wanting to talk to Vanessa. She's our client relations vice president. She's a very friendly person, and a lot of you have already talked to her. But let's go through some of these questions. And Roy, I'm going to ask you, I'll tell you the questions, I'll read them, and let's see if we can answer. So you're saying that a current patient has been seen for a difficult prophy after prophy. and now they can be treated with this code. Well, yes, that's what we're saying, is that you can now be treated with this. Let me see, is she still on here? That's Tracy. Let's see if Tracy's still here. I'm trying to unmute her. In fact, I will try to unmute everybody. Okay, I'm going to try and unmute everybody. Is everybody unmuted now? Let's see, Roy. Roy is unmuted. Okay, Roy, you're unmuted. I don't know how to unmute everybody, but I don't know if we still have Tracy here. Tracy, are you still here? Hopefully we answered your question. And let's see, we have another question. Do you polish at the gingivitis appointment or when they come back? Yes, we do polish when they are at the gingivitis appointment, right? That's
Yes.
part of it. And then let's see, we have another one over here, another question. 6 weeks we did that. Yeah, so you want to make your own determination when that patient is to come back after the gingivitis code. It could be a week, it could be 6 months, or somewhere in between. What is the general fee? We said that it's about, like, it's in between, 1.5 to 2 times of your prophylaxis fee. And that is completed. The gingivitis code is completed in one appointment. Do you charge? Oh, so it could be that they need to come back for another one?
Yeah, could be multiple. Well, you do a portion of the mouth. For example, if the hygienist has an hour, and I hope they have at least an hour, they may not be able to complete the whole mouth, and the patient might need to come back for a subsequent appointment. It would be one code for both appointments billed out at the completion appointment.
So the insurance will only pay for one gingivitis code, not 2 of them. Is that correct?
That's correct, but you're not doing the mouth twice. You're doing part of it and then finishing it. So the entire mouth is done once.
It's done once, but in 2 separate appointments.
Correct.
Okay. So I say that, because we have an overhead, that we can't have patients come for an hour 2 times and not bill for 2 times.
Yeah, you can vary your code. Now, is it going to be limited by the carrier? Yeah, if you're in network, but there's nothing to be said. Even in yesterday's world, before the first, could you bill more or could you charge more for a more difficult case? You could. There's nothing that says the fee has to be exactly the same for everybody. You can vary the fee based on that individual situation with the patient. You can't vary your fee based on a group of individuals. For example, you can't have one fee for your insured patients and another fee for your uninsured patients. That's considered discriminatory based on the fact that they're part of a group. But if it's an individual who comes in who has a difficult condition and a case to treat, can you charge more for that? Yes. And if it's a simple one, can you charge less? Yeah.
Roy, doesn't this go back to, it's like we recommend for our clients that they group what the patient needs. And what I heard you say, which I kind of like, is that you estimate, it's an estimate of how many appointments, what do they need that year? So so because they have to come back for 2 gingivitis appointments, just because their insurance pays for one, you're presenting the total treatment plan and the dollar amount, telling them this is what we estimate your insurance will pay.
Correct. And even if you're in network, if the plan recognizes optional services, and most of the majors do, like Delta does and Anthem does in most states and in most situations. So are there steps that you can go through? Do you need to go through beforehand? Yes, you do. It's just something after the fact and you find out the insurance has only paid a certain amount. You can't go back and charge them extra. But if you've gone through the process prior to, and as I've described, if you present the entire treatment for a year, can you charge more if you have the patient be made aware? It's kind of like an informed consent that they sign. And you explain the insurance is going to pay this amount. You understand that, in fact, we're going to be providing this over and above because of this particular situation. And the patient will sign and says, yes, I do understand that the additional amount will be out of pocket. Most insurance carriers will allow you to do that. You're going to have to attach that to your claims submitted so that the insurance company understands that it is an optional service and the patient has been made aware of. But like you said, this is a whole different lecture.
Yes. So we have just two more questions that I can see right now.
Okay.
Roy, is this code for new patients? Otherwise, how do you present this to an existing patient who's been receiving a prophy in the same condition in the past? This is a great question. Do you want to tackle this question, Roy? I'll let you. You're the expert here on this coding and billing.
Well, as far as the patient who has had a prophy, they've basically had a free ride for a long time. I would explain that, in fact, the situation that the patient has is more severe than the usual patient. And because the insurance companies limited and didn't actually have a code to describe it, you actually had to down code it prior to. But the codes, they have realized that the conditions that exist like yours is over and above what's considered normal, and therefore, and I would certainly explain this prior to providing treatment to the patient, that in fact you're now treating the gingival condition, and that this is the fee and this is the appropriate code to be able to describe the service that you're providing.
You know, this is Madeline. Thank you so much for showing up tonight. I know Vanessa's been telling me great things about you, and Madeline is a hygienist, I believe Vanessa told me. And this is a great question, and I want to say that what we teach is that everything you do needs to benefit the patient. And I think that by talking to your patient, spending some time now to talk to your patient about and show them. Now, don't just talk, but show them what's actually happening in their mouth and how it relates to their total health, and explain to them that now we have this new way to help them get this paid for. So I think that really helps the patient to understand how much you care about them when you're explaining that you're trying to help them not only with their body, but the payment of it as well.
And then I'm going to kind of put a different spin on this, if it's okay.
Of course.
You know, as far as this code, you may use as an incentive to encourage that patient to become more conscientious at home. That patient who has paid for the prophy or had gotten benefit of the prophy prior to, you set them up neat and eye to eye and said, you know, we've got some inflammation here that hasn't resolved, and because it hasn't gotten better, we need to treat this inflammation. We're going to be providing this scaling because you have moderate inflammation. You have moderate to generalized inflammation, and we're going to be treating that today. If you are more conscientious at home, there's a good chance that this can resolve to the point where we can go back to a simple type cleaning. So it's on your shoulders. It's up to you. We're going to go ahead and do what we can to get you healthy today, but be aware that if you aren't conscientious and you come back with the same inflammation, we're going to have to treat that inflammation. Whereas if you treat it at home and are more comprehensive with your brushing and flossing, as we've suggested to you, we can do something simpler. We can go back to the old simple the system that we were using before, and the charge will be less.
Again, that was great what you were saying. That verbiage was really helpful to many people who are listening to this. Thank you so much. I know that's a lot of our clients are looking for this type of verbiage, so that was very helpful, Roy.
Yeah, my pleasure.
So we have one more, and this is a really good one as well, because I read the AAP guidelines all the time, and I know you were saying 50% is, if it's 50% of the mouth that's inflamed, the AAP considers generalized inflammation generalized as 30% of the mouth. So they're wondering, and I know that, I don't know if you weren't being as technical, so I understood what you were saying. It's greater than 30% is what the AAP considers. You were saying 50%, Roy, and both are right. It's their AAP actually says greater than 30%, and you were saying 50%. You weren't saying less or more. You were saying 50.
Yeah, that was. I'll check that to make sure. I thought it came from the AAP, but that was the ADA's definition of. So I'll verify that just to make sure. Thank you for that. And Pam Thoreau is actually the billing person for the AAP. I'll get in contact with Pam and make sure that I didn't misrepresent.
No.
But
we're not trying to call you out. I thought that what you were doing, the reason why I thought Roy was saying 50% is because what I see documented is greater than 30%, and I just thought you were covering the base.
No, like I said, my recollection of the meeting when they were discussing the code and it was asked what generalized was, they indicated that it was 50% or better. So hang on just a second. I'm on the AP website.
I thought I remembered the 30% too, but I just thought you were making sure that it was greater than 30%.
No, 35 generalized. No, I'm sorry. I'm trying to do some references. We're talking here. I'm on the AAP website.
So, Roy, while you're checking that out, I just want to say thank you so much. You are such a wealth of information. And I know a lot of our clients asked for this to, I told them, please register. And then they're going to listen to it later as a team meeting. So, I mean, it was just great to have you. I really appreciate you. I know you got to catch a plane early tomorrow morning, and you're 3 hours ahead on the East Coast. So, we should
I am.
probably.
It's almost past my bedtime.
I know you got to catch that plane early in the morning, so we got to let you get some sleep. But I really appreciate you.
I only have to get up at 4:15. It's all good.
I guess you're not used to sleeping because you're always flying here and there.
It's all good.
So, if you haven't found the answer to that right now, we'll
I
ask
have
you.
not, but I'll talk to Pam, and if you want to go ahead, you have the registration information, and I'll send that to you to make sure that, like I said, it may be that the ADA adopted a different definition, but I want to make sure I haven't given bad information.
Okay, not a problem. I know that you give great information all the time, and that's why your courses are always sold out. So, Roy, you're going to send us all a reference, and we'll look forward to receiving that, and I'll pass it out to the hundreds of people that were on this webinar. Thank you so much, Roy, and have a great meeting at the Chicago Midwinter.
All right. Thank you. Have a great evening yourself.
Good night.